Okay, hello everyone. It's always a pleasure to be in Ireland, and especially today. So I would like us to do one thing before we carry on. Can you take 2 minutes and talk to whoever's next to you and actually just discuss what on earth an outcome is? Because there's lots of muddle about what outcomes is, and it's quite difficult. So just chat to your neighbour and work out together what you think an outcome is. Clearly everyone has a lot to say about what an outcome is, and that's a great piece of news because well, I can stop now. No, it's okay. I'm going to carry on. But I hope you just had a moment to think what an outcome is, because the more I talk about what outcome measures are trying to measure, the more confusing I find that people are about it. So I'm going to try and take us through 4 things. I'm going to sort of start us off talking a common language. And please don't assume that anyone next to you knows the language the way you do, because we all seem to have slightly different interpretations of what an outcome is. And I'm then going to share with you some of the experience we've had predominantly in England. I think I offer it to you for what it's worth. If it's helpful, take some of it. If it's not helpful, leave it. And I would challenge you to try and remember 3 useful things from this talk. More than 3 is usually a bit of a challenge. Okay, so watch out for your useful things. And I'm going to just tell you a little bit how we selected outcome measures for palliative care, and then some of our experience so far with that. So, thinking about the common language, I think we have to think about what it is we're trying to collect, what sort of data, outcomes data is, at what level we're collecting it, and for what purpose. And it may be that we need to adapt to the local context. We heard really clearly from Karen and from Mark about the local context. So just be careful not to be too straitjacketed into any one approach, but think about the local needs. And start by agreeing a common language. I think it took us quite a long time to begin to work towards this when we started this work on outcomes, even though we were able to learn a lot from the experience in Australia. So we heard a little bit already that we need to focus more on outcomes. And if you look at data, some of the data is about the structure of healthcare, some of it is about process measures, some of it is about outcome measures, and even more, some is about experience of healthcare. And if you think about it, outcomes and experience don't go together. Most people think they do, but just take the example of going to see a surgeon for some sort of surgical procedure. The surgeon might be brilliant, the best surgeon in the country, but he may not be really brilliant at communication. So you may not hear a lot about the details, you may not understand the ins and outs of what to expect, but you get a brilliant bit of surgery and you get a good result. So you get good outcome, but your experience might be less than perfect. Whereas you might have a fantastic communicator, but somebody who's a bit rubbish at surgery. Bad outcome, good experience. Okay, so the evidence that we have in healthcare shows that those two don't necessarily map together. So maybe we need to measure experience as well as outcomes. There's also safety indicators, mitigation of risk. And I just want to mention these things to tell you that I'm not going to talk about them. So I'm not going to talk about structure measures. I'm not going to talk about process measures, not going to talk about experience measures or safety indicators. They're all important, but we're going to focus today on the outcomes because they're the most challenging. And when you think about outcomes, it's really taking an approach to healthcare, which is, what is it that delivers high quality healthcare? And I think the definition I like best is the Institute of Medicine one, which is about the degree to which health services increase the likelihood of the desired health outcomes and are consistent with current knowledge, current professional knowledge, because of course professional knowledge moves on and what we know as the current professional knowledge today will not be the same in 10 years. And I think outcome is still used a lot in a very lay sense as the result of something. And we have to remember in healthcare that is not what is meant by outcome. So I will take us back to the Donovedian definitions. Avis Donovedian in the 70s and 80s wrote a lot about how you measure quality in healthcare, and this definition really hasn't been improved upon. It's been refined a little bit, but not improved and not replaced. And basically he said that an outcome is a change in the patient and family, the palliative care, current or future health status. That can be attributed to the preceding healthcare. Current and future. For example, good bereavement care is largely about future health status, future psychological well-being of a family. So it's current and future, and it's a change in health status. So when we think about this, we might think of the structure of what's needed for healthcare, the building, the people, the team, the equipment. We might think about the processes of how those concrete things are used. We might even think about outputs, which are, for example, time in hospital, bed days, or number of surgical procedures, or number of analgesics prescribed. But they don't tell us, none of those things of themselves tell us whether they're making a real difference in the health status of the patients and families we're trying to care for. So I think we've spent a long time measuring structure, process and output things, and it's quite hard to get to outcomes. Still, people talk about outputs as if they are outcomes. If you think, for example, about home death, there's been a lot written about home death in the last few years, and an aspiration to try and improve people's chances of dying at home. But I would also say that's not the important question, where people die. The important question is how they die in that place. It may be important if they have a real preference for home, in which case they may not be so comfortable with not being at home. And so therefore the outcomes may not be so good for them. But the actual thing we want to get to is whether it is a good death in the sense of that person's own priorities and preferences. And that's a really tricky one, isn't it? Because getting to the outcome is quite difficult. So why should we measure outcomes? Because otherwise we have no way of really telling whether our service is doing what we really want it to do. So it's about demonstrating the impact of services at the level of individuals, yes, but also at the level of the cohort or population that service is providing for. And I think we've all heard of the good stories and the bad stories. So in England, we've had a lot of bad stories of poor deaths in hospital. We've also had a lot of good stories of brilliant care from the hospices. But what I'm really interested in is not the people at each end, but everybody. So do we get it right for everybody? Do we get it right for the majority of people that we care for? Can we improve the quality of care for the whole cohort, the whole population that we're trying to serve? So that's a more difficult question than just having the good stories, important as they may be. So it's about having both the stories of the individuals, but also broader population or cohort data that tells us we're doing a good job for everyone. So if we measure outcomes, we get the value. We can measure quality, we can demonstrate effectiveness, we can take a quality assurance and a quality improvement approach, we can understand value and efficiency, which we heard already from Mark, the importance of value. So value and efficiency is about doing the best we can with the resource we've got. We can also do something about complexity. So Karen mentioned stratifying by complexity so that your most complex people are seen by the most specialised services, but the least complex are seen by those who've the skills to deal with that, but not necessarily specialist services. But we can only do that if we can grade complexity from the most complex to the least complex. And also, if we do a good measurement of outcomes, we can start to enable comparisons between services if there is case mix adjustment. And what I mean by that is the variations between services sometimes come down to the differences in the populations they see, and sometimes they come down to the differences in what's being done in those services. And we have to tease those two things out. We have to understand case mix as well as outcomes. So this is just a diagrammatic representation of what Karen mentioned and what I've mentioned. It seems logical to me that specialist palliative care should focus its efforts and energies on the people with the most complex needs. And it should help support others to deliver to those with intermediate needs. And those with the least complex needs, approaching end of life, may well be cared for by their usual care teams, whether it's their cardiologist or whether it's their primary care team. But actually, that's not what happens. We see, a specialist palliative care, we see people in that blue box right across those three strata. So whether you get into specialist palliative care doesn't depend on the complexity of your needs. It depends on things like your age and your ethnicity, your diagnosis, things which are not particularly related to whether you're more complex or less complex. So that is a really memorable diagram. I'd say it's one of the 3 points to remember. We don't see necessarily the people with the most complex needs in specialist palliative care. But outcomes are tricky in palliative care. So if you look at orthopaedics, in England we've got 4 national collections of outcomes data, surgery, orthopaedics, and then 2 others, rehabilitation, and we're developing this in mental health. And in orthopaedics, it's relatively straightforward because you go and get your knee surgery, your knee replacement, and then 3 months, 1 month, 3 months, and 6 months afterwards, somebody does a pain score, measures your mobility and your walking speed. Straightforward, really. You know whether you had a good knee replacement and whether you're doing well after it. But it's much trickier in palliative care. We're not really so interested in mortality or survival, as many specialties are. We may have an interest in that, but we want to know about a lot more as well. We want to know about quality of life and whether we're changing that health status. So whether people are improved well-being, both themselves and their families. The domains are different because they're not disease or procedure related as they are in surgery or orthopaedics. We've got to include families too. It's quite hard to measure the qualitative nature of care. So we know that a lot of what we do is around identity, resolution of conflict and resolution in people's lives, helping them humanly to come to a different place. Now that's quite hard to measure in any outcomes, but I would encourage you to think about outcome measures as a kind of the headlines in a newspaper. They just give you the headlines, they don't give you the detail. You know, it's never going to replace a holistic assessment by somebody with the expertise to do that well, but it's just trying to get the right headlines. It's also, we're trying to measure outcomes in the context of declining health. So things may be getting worse, and improving outcomes may actually be maintaining things at a level rather than allowing them to deteriorate. And it's really important that commissioners and funders of services really understand that, because if you regarded it in the same way as knee surgery, you'd have a problem. So several years ago, we started a project in England called OACC, the Outcomes Assessment and Complexity Collaborative. But we call it OAK, and we use an oak tree as the little symbol to remind us of it. And the work was to identify robust, relevant and feasible outcome measures for palliative care and to implement them into practice in a variety of palliative settings across South East London. But we very much came at this that we would learn as we went along. We didn't have fixed ideas. We didn't set out with a particular set of measures. We said we're going to be open to learning from others, and we had great support from some of the Peacock team in Australia. But we also collected data and information as we went along about what works and doesn't. So you'll get the benefit of some of that learning. The other thing that we were surprised by was how much it took off across England. So at the height, the team only ever had 5 people in it, and yet we found very quickly there was a huge interest across England. And so with the help of Hospice UK and other national organisations, we were able to then take it up to a different level. But we weren't really expecting that at the start. So, question 1, how did we decide on what measures we were going to choose? So we spent a long time working with services and going back to evidence to iterate this. And it was based on 4 steps. We reviewed the evidence in the literature on outcome measures. We followed something called the More Care Guidance, which is guidance that was produced through expert consensus on how to do this in palliative care. We drew on some previous survey data about the use of outcome measures, and we also reviewed the evidence more broadly on what people's priorities are as they face an advanced life-threatening illness. I'm just going to gallop through this quickly because you can easily look at it if you want to, and I've only picked out a few headlines, but there was a lot of evidence out there already about what measures there were around, both clinical reviews I've put there, and then we actually undertook a review ourselves to try and understand whether using outcome measures itself made a difference for people. Bottom line was it probably does improve symptom recognition, and it probably improves emotional well-being for people because they feel a bit more confident that everything they have that's an issue for them is going to be listened to and addressed. The More Care Guidance is very clear about what we should look for in outcome measures for palliative care. So we want measures which are responsive to change over time, really important in the context of a deteriorating illness. It's got to be clinically important, so it's got to matter for patients and families and professionals. We probably also need reasonably good proxy measures. And what I mean by that is, measures where they can either be reported by the patient or they can be reported by family or staff if the patient is too ill. And that's critically important because we know about 2/3 of inpatients cannot self-report their own measures at some stage during their inpatient stay. And we know about 20 or 25% of community palliative patients can't report their own measures. Those are rough figures because it depends on your population, but it gives you some idea why proxy measures are probably important. We needed to be clear about the definition of the time points because an outcome measure is trying to capture change in health status. And if you're going to capture change, you need a time period over which to measure it. If it's 2 days, you're going to see something different from if it's 2 weeks or a month. So we had to think about the time points, and we also had to have measures that were psychometrically robust. So that basically means valid, they measure what they should, reliable, they behave in an expected way if I use it or you use it, or we use it at different points in time, and also responsive to change over time, which I've already mentioned because it's so important. Okay, so we needed to find these kind of measures. There's a very interesting survey by one of my colleagues, Richard Harding, who looked to see what measures were being used. Now, it's a little bit old, but I wouldn't be surprised if this wasn't so different. He identified 116 measures in clinical use. 6 of them were reported more than 40 times. 99 of them were reported less than 10 times. What that's saying is that there are a small number of measures used a lot, and there's an awful lot of measures which, you know, they're locally used. So 2 or 3 or 4 teams use them in a little locality, but they're not widely used. So we were really wary of this because we didn't want to be using measures which weren't going to be nationally or even internationally applicable. Because once you start to measure things, you start to get into the possibilities of comparing services. And of course, if you're using different measures, it becomes quite tricky. So we wanted to recommend measures that would be reasonably widely accepted nationally and internationally. But perhaps most important of all in our work to develop this, we really wanted to root the things we were capturing in the things that are important to patients and families as they get towards the end of life. And there's a lot of research being done on this over 30, 40 years. What is striking to me when we reviewed it is that the same stories come up again and again and again. I've quoted a bit of the evidence there, but there's lots of it. And people report the same things, and they won't be a surprise to any one of you who's clinical. People worry about good pain and symptom control. They worry about the burden on their families and trying to lessen that burden. They want their priorities and preferences for care listened to and accorded with where possible. And most people are fairly realistic about what's possible. The patients themselves also want time for preparation, for achieving some resolution and a sense of peace as they come towards the end of their lives. That isn't something that families particularly prioritise, but if you look at the qualitative evidence discussing with people who are near the end of life, that is important to them for the most part. And lastly, they want well coordinated and well integrated care, so they don't have to keep spending time building a relationship with another professional and having lots of different people involved in care. They want some continuity and coordination. So, bearing all those things in mind, the evidence, the more care guidance, what we were looking for in measures, and the things that are important for people as they get towards the end of life, we came up with this sort of conclusion. We thought we needed to measure changes in symptom severity and in functional ability, changes in family anxiety and distress. We thought we should look at information needs, and we felt very strongly that the idea of contextualising what phase of illness somebody was in was actually really important, because it gave you a sense of the urgency of their care needs at that particular point in time. Particularly important for planning ahead and understanding their priorities. And we also thought it was really important to capture change in people's emotional well-being or preparedness. We also thought continuity was important, but we couldn't find a measure of continuity and coordination that was easy enough and brief enough to include in the package. So that sort of is sitting there on the too difficult for now a list, but we'll maybe try and tackle it as we go along. So we ended up with 6 measures, and having worked with the teams at great length, I would say they are now prioritised to 3 measures with a possible 4th. And they are these. They are Phase of illness, giving the context of the acuteness of what was happening for people. Functional status, measured using the Australian modified Karnofsky performance score. And then problem severity, using something called the Integrated Palliative Care Outcome Scale. The fourth measure is actually Bartel, which is not so much functional status, but dependency in terms of activities of daily living. So those are the four that we have found most valuable, both from the development work and then from trying to implement them into practice to see how they worked. And I'm sure when we hear from David about the work in Australia, you'll see really strong resonance. That's no mistake, because we were in conversation with the Peacock team a lot of the time that we were doing this work. You may all be familiar with the measures, but just in case you're not, I'm going to just outline them. Phase of illness is assessed by staff. It's one item, and it just is an assessment of whether somebody is unstable, stable, deteriorating, or dying, or bereaved. So unstable is about when someone has acute and unexpected issues that need to be addressed as a matter of priority. Stable is when they don't have any particular needs. Deteriorating is when they have expected and more predictable needs. So there is an awareness that these things may well happen and there's a plan in place to address them. And then dying is within days of death. The Australian Modified Karnofsky Performance Scale is a 11-point scale from 100% to 0, where 100% is full function and 0 is dead. 10% would be somebody who was maybe unconscious or semi-conscious and completely bedbound and so forth. So that's quite straightforward. Again, it's a one-item measure and it's assessed by staff usually. The IPOS is what I call a global measure of palliative needs. So I'm going to move on to what's in it. The first question is for someone to say for themselves what their main concerns are. And that is great because it's an open question. It allows somebody to set the scene themselves for their priorities. And I cannot tell you how revealing that is in clinical practice. I'm very often surprised by what people say. We then have a symptom checklist, asking people to say how much they're affected by a range of common symptoms. We ask about anxiety or worry in relation to their illness or treatment. We ask about family anxiety or distress in relation to what's going on. We ask about feeling depressed, whether somebody feels at peace or not. A very revealing question for people of all cultural backgrounds. We ask about ability to share feelings with family and friends as much as somebody wants, which allows for those people who don't want to share feelings, as well as those people who do, and it's a problem for them. Also about the information in relation to what's happening to them, practical issues, and lastly, how the questionnaire was completed, which allows for us to understand whether it was patient completed, patient with help from family, with help from staff, or purely staff completed. And those versions have been validated. There are subscales which help you look at physical aspects of issues for people, emotional aspects, and the more communication practical issues. There's also a short form which has only 5 items: pain, breathlessness, anxiety, being at peace or not, and information needs. And the reason we picked this measure rather than a simple symptom scale was because we wanted something that was global in the terms of the domains that it covered, so that it wasn't just symptoms, it wasn't just a biomedical view, but it was actually reflecting what we had gathered from the evidence about what matters to patients and families as they approach, with an advanced illness. And also, it's valid, reliable, and responsive to change. It's robust psychometrically. I've just put this in because people are concerned about what a meaningful change is. We actually asked a large cohort of patients in the validation study to tell us whether they felt things were improved for them or not, or worse, and we related that to their scores. And what this shows is that a 4-point change in their IPOS score is meaningful in terms of what they report as benefit or deterioration. So we have 4 measures, 2 of which are single items collected by staff, 1 of which can be collected by patients or staff, and then Bartel is the additional one I mentioned, which can be collected by staff, 10 items. So not overly onerous, which was important. But we did have to think about the timing of measures, because as you remember, we were talking about change in health status. And we thought quite hard about this, and we opted to follow phase of illness. So that means we don't have fixed time points, 48 hours, 1 week, 2 weeks, but we actually follow change in phase of illness. And the reason that is helpful is because then the timing of the measures follows clinical care. So somebody might come into an episode of care, we would assess their phase of illness, their Karnofsky and their IPOS. We would then monitor phase of illness on a daily or contact basis, and then when they change phase, we would remeasure AKPS and IPOS, and so on. And we developed a lot of resources to support the implementation of these measures. We've also recently launched a community of practice in England, which is supported by Hospice UK and their virtual platform for resources. So we launched training packs, which I know some teams here have availed themselves of, with booklets. Version 2 is the current version, but we're just about to publish version 3. How to implement the measures, another booklet. How to implement patient-reported outcome measures into practice. A clinical decision support tool to help decide what to do when you discover high scores. And this all was aligned with some of the work going on in England around developing commissioning for palliative care and developing a national outcomes data set. So the national teams selected phase of illness, AKPS and IPOS 5 for national rollout. So we've been asked, since we've done all this work, a lot about the reporting of the data, and we've worked quite intensively with our core sites to develop some of the thinking around this. Again, we didn't fix things and say, we think you should report this. We actually iterated this with the teams. What's useful to you? What do you find helpful? What do you want to know from your data? So we found that understanding the distribution of phase, AKPS and IPOS scores at the start of entry into a service is really helpful, because that tells you about case mix. It tells you whether your patients are different from the patients being seen in the service down the road. So that has been really helpful, and we're developing that further. We've also found that length of phase, particularly length of unstable phase, is very helpful. And the reason is that if you think about it, these are people who may not have very long to live, maybe weeks or a few months. If you can get them out of the unstable phase quicker, you're giving them better quality days. So you can stabilise them, or even if you can get them into the deteriorating phase, they're getting more days that are good quality. So the teams are really focusing on how to reduce the unstable phase of illness. and that's really helpful. They're also looking at changes in IPOS scores by phase, and it's particularly helpful when you look at the change in the unstable phases, because actually that's a lot of the high intensity work that we do in specialist palliative care. So, time in unstable phase, changes in the scores over phase, over the duration of phase. We've looked at some of the items and some of the subscales, and we've also looked at the proportion with moderate, severe and overwhelming symptoms and how many of those can be reduced to absent or mild. So I'm just going to give you this one. This is showing all of the different IPOS items down the left-hand side and the proportion of people, and they're quite big numbers there, several hundreds of people. How many of those people have moderate, severe or overwhelming pain? And what I wanted to tell you was that this really revolutionises how people think, because we all know that we focus on pain and we focus on breathlessness, we focus on some of the other symptoms, but actually the teams were saying weakness, poor mobility, they're really common. Why aren't we doing anything about those things? And so they're starting to look at short-term rehab interventions to intensively work with people 2 or 3 sessions to improve mobility, to enable them to manage their weakness and work with it, and maybe even improve things a little. So it's shifting some of the balance of what the teams spend their time doing. Another one is family. So family anxiety and distress is really high. And some of the teams did some work with us to look at the amount of time they spend with families, and they recognised it wasn't very much. So they were thinking, what can we do to really focus on the family needs and improve things for them? So beginning to shift how they think about that. So what this data does is it gives you a picture over your service to what the problems are, where to focus the resources. This is also another approach to data. It may look the same, but it's reporting different data. So it's saying, of the people who have moderate, severe and overwhelming pain, how many of them have got to absent or mild pain by the end of their first phase of illness? And really what we're trying to do is push those figures up so that we know we're doing the most we can for people in an intensive period of time. We're looking quite a lot at unstable phase. There's still a lot of variation. So you can see here that there's a lot of variation. Some people stay in the unstable phase for a long time. How can we focus resources to help with that? Sometimes we've presented these radial plots which people find intuitively easier to understand. So this is 90 people who were unstable at the start of their episode of care and then were discharged home from hospital at the end of the episode of care. And it shows the mean score for each of the IPOS items, and the red line at the start of the episode reducing to the green bar, the green middle star, by the end of the episode. So it shows very clearly what has been able to be achieved for those people. And there are other ways that we have demonstrated it. This one is quite helpful because it's showing every individual patient looking at their change scores. So the people who are under the line on the left-hand side are people who've improved. And the people towards the far end, with the bars above the line, are people who've got worse. But it begins to show you that in spite of the fact these are people with advancing illness, 60% or more are improved. So I think we are doing a huge amount in palliative care, but this allows us to systematically demonstrate that impact in a systematic and logical way. There have been a lot of challenges, so I'm going to be honest with you about these. The biggest one is actually staff collecting data but not seeing the results, and we've been really encouraging teams to introduce some feedback on a regular basis, and we're applying for further funding to do that more widely and more systematically. There's been some inconsistency in how people have applied phase of illness, and we've been trying to steadily address that through training, through videos and so forth. We've been successful sometimes at getting first assessment data, but less good at getting the follow-up data, but gradually that's improving. There's been some challenges assessing the IPOS items in the unconscious or dying phase, and we're going to address that through a modification of some of the IPOS items for that setting, which is going to be published soon. And we've had some teams that focused on measuring the people who it was easiest to measure. So they kind of over-measured everybody in daycare or in outpatients, rather than focusing on the whole of the service. It does take time and effort, and it does take a bit of a culture change. People sometimes feel threatened by it. Staff sometimes feel it's about performance measurement, which it is not. And sometimes you do have to shift the skill mix so that you've got somebody in the organisation who can work with the data and help use it for your local purposes. Sometimes people don't quite know how to analyse the data, but we've been trying to hold workshops to train people so that it's consistently reported. And I guess the biggest thing I would say is that you want to get people in the team to ask their own questions of the data. So we had a nurse I was working with who had done a bit of training on breathlessness management, and she really wanted to know of the people seen by the team details about how common breathlessness was, how often it was improved or not improved. And so we were able to extract that part of the data, and she was part of the group that fed it back to the whole team, and it really made sense. And I think the more you can do that and use data for local purposes, clinical staff as well as the team leads and the policy makers, then the more valuable it is and the more this begins to make sense to the staff on the ground. So there's a lot of other people who've been involved in this work, and I just wanted to say that the Oak team at King's and the funders, the guys in St Thomas's Charity, particularly the funders who really understood what this was all about. It's great to have their support, and thank you for listening.